Hello and welcome to this special edition of NJBIZ Conversations. I'm your host, Jeff Kanaj. My guest today is a familiar figure to NJBIZ readers and to New Jerseyans in general, especially Giants fans. He's the CEO of Hackensack Meridian Health, Robert Garrett. Bob, welcome back.
Thank you, Jeff, for having me, and Happy New Year to you and to all my fellow Giants fans. Hopefully, it's a better year in 2025.
Indeed, from your mouth to Mara's ears. So, I wanted to start with your annual trip to Davos, which I understand is coming up fairly soon. I think in the next we're talking in early January, so I think the World Economic Forum event starts on the 20th. In years past, we've talked a lot about artificial intelligence. That's been a big focus. Is that the same? Are you going to be working on the same issue this year, or what's different going into to Davos this year?
Jeff, this is the second year that I have the privilege of chairing the healthcare community out at Davos at the World Economic Forum. And you're correct. Last year's focus was on artificial intelligence and specifically how it can improve some of the global healthcare challenges like quality, like better access to care, better access to prevention, and also how it potentially could help us with workforce shortages. So we're going to pick up on that a little bit. So we're gonna talk a little bit about AI again and see the progress that we made since last year and assess that a little bit. But we're also going to pivot to a topic that's related but a little bit different in that we're going to talk about financing of healthcare systems from around the globe and making sure that we talk about what's stable in order to support better access to care and better quality of care. So, AI might be, one thing that these financing systems invest in, but there are other technologies, there's other means. So we're going to explore financing models such as all payer systems to fully privately funded healthcare to maybe hybrid models, which seem to be, by the way, the best practice out there around the globe in terms of who's getting the best healthcare outcome results are those countries that really collaborate, meaning the private and public sector collaborate in terms of financing. So we're going to focus a lot on the financing models and how that can impact some of those global goals I spoke about.
Right. Now, how would a hybrid model work? I mean, obviously public and private, meaning government funding, and then what else? Maybe the insurers and all, or
Insurance funding, private funding, employer funded, healthcare. So it could be, you could even call the U.S. system, a hybrid model. But I know some of the best practices out there, at least in the Western world, are in Germany, in Switzerland, in places like that, where there is truly a collaborative partnership between governmental funding and private funding. So we're going to take a look at some of those best practices. We're going to have the health ministers from some of those countries in Europe be there, as well as in Asia and Africa. We're gonna talk a little bit about the U.S. experience, what has worked from the financing perspective, what has not worked, and then we're gonna pivot at the end of the governor session. We're gonna pivot it with the new administration coming in Washington. How can we as a healthcare community engage in these policy discussions as the new administration takes hold? What are the healthcare priorities? How should we weigh in on those priorities? So we're going to talk a little bit about that. So more of a strategic perspective of what our role should be as particularly in Washington with the new administration. Now, obviously, there's some new governments coming in Europe and in other places as well. So it won't just be about the U.S., but that's our focus as well.
okay. Well, and I do want to get into that a little bit later, but I just do want to ask a little bit more about this question, because what occurred to me when you said that was that sounds a lot like the system we have in the United States, which I don't think is terribly popular around the rest of the world. I'm curious as to whether you have a sense that there's an openness to that kind of thing in other countries, where arguably they get better outcomes at less cost.
And I think where they get better outcomes at less cost, like as an example, in some of the European countries, is because there's a focus on prevention. There's a focus on primary care and preventing chronic disease. I think in the U.S., although it is a private-public partnership, if you will, in terms of the funding of healthcare, the priorities may not have been the same as in Europe and even in some Asian countries. So I think that's really where the differences are. And we're going to talk about that because we don't want to just create a private-public partnership if the dollars that are spent are not being effectively used to really improve health status and healthcare outcomes. So I think I think you're right to point that out because that's an important piece of it.
Okay. Now, and then just in terms of artificial, getting back to AI, you did say that was going to be part of the discussion, I'm guessing.
Yes.
What's new this year? What are you thinking about? What are you working on in that area?
Well, in terms of from a global perspective, we have another year of experience with some of the AI algorithms, some of the pilots that have gone on in health systems, as an example, not just in the U.S. but around the globe. So we're kind of, I think, honing in on which areas we think have the biggest potential. And I think it probably boils down to on the clinical side. I think predictive analytics can be very, very helpful for clinicians to identify disease states earlier on, and then therefore hopefully prevent the worst that disease could bring on, and maybe even prevent it entirely. But certainly those predictive analytics tools that AI holds promise for is certainly something that I think we have more experience. I think certainly more focus in those areas. I think on the workforce front, I think I think we found the learnings over the last year of that there's a lot of potential for AI and AI assisted technologies to really help us augment the workforce, whether that's through remote access, as an example, virtual programs like virtual nursing that could be powered through AI, or making or enabling the healthcare workers that are on the front lines more apt to do direct patient care in these times where there are workforce shortages, and using AI as an example to help doctors summarize their notes, to help nurses with discharge summaries and admissions processes, which are very, very time consuming. So, when you're short staffed, you want the workforce that you have to focus as much attention as they can directly on patients. So we're finding that that's a big area for AI focus. So I think there have been some good lessons learned over the last year. I think last year it was a little more of a broad spectrum. Okay, we threw everything out there. And I would say the two most promising areas, in my view, are the AI applications that will help us with the workforce. And by the way, by doing so, will also help on the affordability issue of reducing healthcare costs. And the second piece, of course, is really on the clinical side and on the predictive analytics side.
Okay, I ask about AI because it's top of mind. We actually have we're moderating one of our panel discussions is on artificial intelligence next week. So I know that there's a tremendous amount of interest in it. We get an amazing response to these kinds of things. There's a lot of interest, and what I'm hearing, what I'm seeing anecdotally, is a lot of the early resistance to AI is really breaking down, and there's a lot more openness to it. I'm wondering if you're hearing the same thing in your work, particularly with folks around the world and at the World Economic Forum.
Definitely a lot of that resistance is breaking down. I think there's still concerns about governance and making sure that data is accurate, that patient privacy is protected through these processes. But I think as it's becoming more well known, more accepted, we have, as an example, at Hackensack Meridian, I mean, we have a real significant interest from our clinicians, from our doctors, our nurses, who want to see more AI pilots developed to really assist them in their day-to-day functions. And and we're seeing more acceptance with patients too. I think as long as patients are educated and families are educated on the use, and that that it doesn't mean that a human is still not going to make your final diagnosis or sign off on treatment plans and develop treatment plans, which they are. I think as long as it's explained that way, that this is, like, as an example, another pair of eyes for a radiologist to view a scan and maybe identify a breast cancer earlier on. I think patients, when they understand it in that context, are much more supportive. So there's definitely much more support from a variety of constituents for AI to move forward. So we're at HMH, we're definitely embracing the technology in a big way. And we beefed up our team that has AI capabilities, AI expertise. We have a broader group of the folks that are prioritizing AI pilots. So I think that's happening not just at HMH, but that's happening really in health systems all over the U.S. and around the globe.
Around the world. Yeah, and it's the human involvement. I think again, from what I hear, is what really helps to get people comfortable with this idea that it's not just going to be a machine that's actually making decisions. There are going to be human beings behind it. Again, from in your discussions, is that part of what you're hearing from the folks you're talking with at the World Economic Forum and elsewhere around the world?
Yeah, I think it's an important component. I mean, having the human component involved every step along the way and actually overseeing it, particularly in healthcare, I think is really important for folks. I mean, that just gives a lot more credibility. And from a safety perspective, people are embracing a lot more with that understanding. It's kind of, it's like the analogy of pilotless planes and cars that drive themselves. I mean, people still have some reluctance there. They want to make sure there's still some human intervention in those activities. And certainly, in healthcare and making healthcare decisions and diagnoses and treatment, it's important that AI is used as a tool that really it helps and enhances human beings' ability to do the right thing.
Okay. So given all of that, what do you hope is going to come out of the discussions in Davos on the financing model with the AI component? I mean, are you hoping to develop a model as it were that could be put into place elsewhere? What do you think the product might be, if not, after January 24th, sometime in the future?
I think what it probably won't be one model per se, but I think what we will be able to do is endorse, several models, maybe all under the umbrella of this hybrid, public-private type of partnership, and really identify some best practices out there that maybe we can then go to policymakers, and they will be part, like I said, they'll be part of this discussion as well. So we'll have health ministers from different parts of the world there. But we would like to then, have an action plan that would go out and say to policymakers, in order to improve access, in order to improve quality outcomes around the globe, we need more stable financing process and system. And here are our ideas for best practices.
Okay. Now you mentioned the new administration in Washington. I'm curious as to how receptive you think those folks are going to be to first of all to any sort of to anything that's going on now. I mean, are you concerned? I know a lot of folks are concerned about what they see happening there with the kinds of appointments that the president-elect seems to be making. Are you concerned at all about the direction that he seems to be taking, or are you just going to wait and see what happens?
Well, I certainly want to, I want to give the new administration the benefit of the doubt, and they haven't taken office yet. So we want to see exactly what's going to happen once they take office and what direction they're going in. And, there's, like any new administration, there's things that you worry about, and there's things that you're encouraged about. So as an example, putting the personalities aside, but in terms of policy, if they're going to, if one of the priorities is going to be to attack chronic disease in the U.S., that's a good thing. I mean, I think, our rate of chronic disease compared to other Western democracies and Western countries is a lot worse. And maybe it's because we haven't, put our attention on prevention and primary care. So if that's going to be the focus, and really kind of attacking the drug issues and the food issues and the exercise issues, I think that's a good thing. I mean, that's certainly part of our mission at HMH to transform, healthcare. And we can't do that without, really attacking chronic disease. But where I get concerned is if we are going to put policies in effect, or even in attacking chronic disease that are not science based and are not based on good scientific principles and good data. That's where I would get concerned, because then, we could be making some decisions that are going to be counterintuitive. And I do worry about, vaccinations, and I do worry about things of that nature, because, we're and especially, being on the world stage at Davos, and you hear in some countries that don't have ready access to basic vaccinations, there are epidemics, particularly with children, that can be prevented. So we want to make sure that decision making in any administration, but in this administration in particular, is based on good science and good data. So that's really where my concerns are. But if the focus is going to be on improving health status in the U.S. by reducing or eliminating some of the chronic diseases that we have out there, that I would encourage that. I think it's a positive development.
Okay. Now, I assume before since you're going to take up this issue in Davos, that you've done some work on this. I'm curious then, is Washington's role central to all of this, to the kinds of things that you're talking about, or can it be on a state by state or even county by county approach? Does it have to be centralized, I guess is what I'm saying? Is that what is that going to be the focus of what you're talking about, or is it sort of more wide open, where it's the kind of thing that smaller governments can pick up and work with, or smaller countries, smaller jurisdictions, and smaller institutions?
Well, I think one size does not fit all, but I think there'll be some principles that will come out of that, will be applicable for, smaller governments, as well as, a big centralized national government approach. But I do think, look, if we're gonna attack areas like obesity and chronic diseases, I think you have to do that from a national perspective, because I don't think it's going to work from a state by state perspective. But I also think on policies like, vaccination, again, epidemics and pandemics and diseases in general don't stop at state lines. I mean, they go across those state lines. So we got to have some consistency there. I think, individual states, will have, differing healthcare policies and priorities based on data in their states, because what might be the highest priority in Mississippi may not be the highest priority in New Jersey. So I understand the need for that, and I think each public health system in their respective states should have their own role. But I do think the central government in Washington does have a major role to play in governing healthcare policy, and I'd like to see that continue. And and we as and going back to Davos, we as a World Economic Forum and a healthcare community, we've already started our outreach. We had a very successful session, as an example, with Senator Cassidy, who's going to be the new incoming chair of the Health Committee in the Senate, and and talked about some of our concerns, some of our priorities. And he was taking, I have to say, it was a Zoom like this, and he was taking rigorous notes. And we're hoping that kind of thing will continue. And after Davos, one of our priorities is going to be to meet with leaders in the new administration, maybe particularly even RK Jr., maybe Dr. Mehmet Oz and folks like that. But also on the congressional side, those folks that are going to have a big influence in healthcare policy.
Okay. And what about the financing piece? I asked because there have been efforts on the part of some states, including New Jersey, to try and work on different financing models for funding health, for health insurance, for getting people covered. Is that something that's part of it? Because there likely will be and has been some hostility from Washington, from hostility from other states to the kinds of things you're talking about. Is there a role for the states in what you're talking about, particularly on the finance side?
Yeah, I think there is, particularly when it comes to Medicaid, funding, because that is a partnership in terms of funding to the federal government and the state government. And I would encourage states, and New Jersey has taken advantage of this, but to maximize the dollars that are available for Medicaid funding, because poverty continues to increase in our country and in our state. In New Jersey, as an example, I think 10% of the population is under the poverty line. So it's a big issue. And for us, particularly at Hackensack Meridian, where we have two children's hospitals, Medicaid funding is a huge issue because a lot of patients that we see are covered by Medicaid. So yes, I think there is a big role for the states to play. And listen, I'm not the governor of any state, so I don't determine that policy, but I would advocate that states, and certainly our state here has done a good job on that score, and that is to maximize the dollars that are available for Medicaid funding. Because if people become uninsured, that's not good, because number one, where will they get the access to healthcare? Typically what happens is uninsured individuals will seek primary care in emergency departments. And that's not the best place to receive primary care. It's not good for them. It's not good for their outcomes. It's certainly not good for the healthcare system, because it drives costs up significantly as well. So I do think, I'd be an advocate for not letting the level of insured Americans drop. I think, if anything, as our population ages and as we have more challenges moving forward, we need to have more of our population insured rather than uninsured. So I'd certainly be an advocate in Washington and at the state level for Medicaid funding.
Okay. And that leads to the next thing I wanted to talk about, which is health equity. You and I have talked about that a lot in the past. I know it's a particular interest of yours. Have you made any progress on that? Take it wherever you want, whether at HMH in particular, or in your discussions with other healthcare leaders around the world. Where do you think we stand now in terms of trying to produce better outcomes for everybody?
I think we are making progress. We're seeing, first I'll start with Hackensack Meridian. Number one, I think I mentioned to you last time we had a chance to speak that we implemented a program where we're screening individuals for the social determinants of health. That program continues to increase. I think we've screened 1.8 million people, and we've made 4.5 million referrals for people to get help. And that screening process has really increased in terms of the size and the scope. So we're screening for those social determinants of health. We're screening for things like somebody who might have been human trafficked, or we're screening, and that just started recently at Hackensack Meridian Health. But we're also screening for folks that might have had sexual violence or sexual abuse. So those efforts are, I think, helping with health equity, as certainly as people are getting more and more help through these referrals. I think we're also seeing some results. I think we've had a good track record. As an example, we focused on the last few years on reducing child, infant, and maternal mortality, and we're seeing some really good results there. I think we didn't burn. I think for a second straight year in 24, we didn't have any maternal deaths within Hackensack Meridian Health. So I think some of our efforts in focusing in on some areas that we felt were not getting equitable access to healthcare, where now we feel that we're doing a better job there. That we've seen some significant results there. And then our hospitals this past year, which was really significant, every one of our hospitals became certified by the Joint Commission for their work in health equity. We were the first hospital in the country, because in the first health system in the country, to get that certification. what that means is important. That means that good work is going on within our hospitals to close these equity gaps and to identify areas where outcomes need improvement. So I'm really proud of that track record. So I think, at HMH, we are making progress. I think on a national scene, certainly there's more talk about it. I hear more of my colleagues out there making it a priority within their health system. And then at the global level, certainly it's a big issue. And one of the, in addition to what I'm doing with the governors community at Davos, I'm also going to be featured on a panel regarding health equity at Davos. So
Okay.
going to be hearing about some of the progress that's been made around the globe on health equity and maybe some of the challenges that still exist. So it is definitely, let me put it this way, there's a lot more awareness that it is an issue that has to be dealt with. And I think, in our case and in other, other health systems, they're starting to make some good progress.
Okay. Now, you mentioned that it's a priority for your colleagues, and I get the same sense in talking to people in positions like yours. I'm wondering though, if you think it's enough of a priority for others who are involved, other stakeholders, for example, government at all levels, federal, state, local, the business community writ large, supermarkets, food producers, things like that. Or is there that kind of awareness, enough of that kind of awareness out there to make a real difference, or do you still have a lot of work to do?
I think there's still work to be done, but I'm encouraged because, as an example, last year we did partner with supermarkets, with grocery stores on a program called Fresh Match, where we're making available through the extension of the SNAP program fresh fruits and vegetables to people in areas where they don't normally have access for those types of healthier foods. And that's been a great collaboration with supermarkets and grocery stores throughout the state of New Jersey. So I do think there's definitely more work to be done there, Jeff. There's no doubt. There's more awareness, but there's more work to be done. But I am encouraged that, we're starting to see these kind of partnerships. You're also seeing, some insurance companies, whether it's Horizon in New Jersey, but even national companies like Aetna and United that are partnering with health systems now and trying to address health equity in communities, particularly underserved communities. So I'm encouraged that we're making progress, but I couldn't sit here today and tell you that there's not still a lot of opportunity. There is. And I feel a responsibility as a healthcare leader to, help spread that word and encourage these kinds of partnerships, because that's the only way it's going to get done. I mean, we can't do it all by ourselves. We're going to need these other stakeholders to partner. And even in government too, I think, we have to continue to make the case that putting money into health equity is really going to be the way to transform healthcare in the U.S.
Okay. And around the world, is this as big an issue in other countries as it is for you here? First, among healthcare leaders, in people in your position in other countries, but then also public policymakers and just the public at large. Is it widely recognized, and where's the United States rank in terms of how we view this and how big a priority it is?
In the U.S., I think it's more about certain populations have better access to healthcare, better access to food, better access to housing and transportation. I think in some of the underserved countries around the world, there is a big awareness, but their issue is that their entire nation doesn't have the right access to good quality healthcare. They don't necessarily have stable transportation or housing situations. So, they're dealing with it on a much broader scale than we are in the U.S. That's not to say that it's not a significant problem here. It is. But when I talk to some of these health ministers in some of the African countries, some of the Asian countries, I mean, they have it on a big scale, and that's why they're very interested in participating in these discussions, because to the extent that we can help by just even talking about some of our best practices and experiences, just even telehealth. I mean, some of the discussions we've had in previous years at the World Economic Forum, and just, folks using their iPhones to get a primary care visit because they don't have transportation to get to doctor, or they're out in a rural African community that's 100 miles away from the nearest provider. One thing that seems to be universal are that people do have smartphones. So they're able to, through our experiences, they're able to then extend those to some of these countries, which, I'm encouraged about. But, definitely, as I said before, definitely a lot more work to do.
Okay, well, that's sort of what I was asking about was really in terms of other industrialized countries, and it's interesting that you say that the phones are sort of ubiquitous no matter where you go, because I mean, just you know as a theoretical matter, it would seem like it'd be easier to do that in a country in a country like the United States or like Great Britain or Germany or France, places where there is a well-developed technological infrastructure. Is that necessary for this? For the push for better outcomes for health equity.
Yeah, so we have, we've told those health ministers that, they should, since folks do have the smartphones, to invest in that infrastructure so that that's much more effective. Because, there was a time where we said, okay, well, we need more, primary care physicians in some of these rural areas. But, it's just not realistic to get primary care physicians in all these rural areas and these remote geographies. So again, through technology, and that's the beauty of technology, what's happened over the last few years is you can have an effective, physician's visit, and you can, they can prescribe medications and get folks on a good treatment plan through telehealth. And so we've encouraged those countries to invest in that kind of infrastructure, because it's not always there, to your point.
Right. Okay. And so, how big of a component of what HMH offers is technology? Because I'm asking because I'm going to get to the point of community outreach and going out and be, as you've said before, being where the patients are, meeting them where they are. What is the mix now in terms of telehealth and using technology and using all of the tools, the hardware and software that you have at your disposal, as opposed to being out and meeting the people where they are and making sure that they're living their lives in the best way that they can.
So it's a mix, but I think, certainly the use of technology, the use of telehealth, the use of remote monitoring of patients has been a big priority for HMH. So just to give you a couple examples, in the past year, we put three pretty, I think, unique but innovative partnerships together in this space. One is with, and I think you guys might have covered this, is K Health. So K Health is a virtual primary care provider, and through technology, we launched this program. And these physicians who are remote are their virtual visits, where patients have virtual visits with these primary care physicians. That got launched this year, and that's off to a great start. So I actually even have, I think, some stats here, right? Let's see. I have, we just got that launched in mid October, and we've already had almost 2,000 visits from mid October to New Year's in K Health, and that's just a new entity, a new partnership. So that's going to continue to grow, and that gives people access to a primary care physician that maybe didn't have access before. Another example that we launched this past year is the partnership with Medically Home for hospital at home. And again, remote monitoring through a command center. That technology is now being used to monitor patients 24/7. There are some people that say not only is the quality as good as if they were being seen in a hospital, but a lot of people are making the case, and there'll be more studies that come out on this to validate it, but that the quality is even better than in a hospital, because you have a doctor literally, monitoring these patients 24/7. In a hospital, that's not always the case. I mean, there are certainly staff that are there 24/7, but this actually, could enhance quality. Patients are happy. The patient satisfaction, patient engagement with the hospital home program has been very, very high. And that got off to a great start too. I have, some stats there. We've exceeded expectations. We just launched it in 3 of our hospitals, and we've admitted 530 patients, so more than 530 patients since the launch, which was in the fall as well. So, and what that's also doing, Jeff, if you think about it, is it's freeing up capacity in those hospitals, because those patients stayed 7 to 10 days in a hospital stay, occupying a acute care bed. And, with those hospitals and at full capacity, that allows us to take care of additional patients. So yes, the technology is being deployed significantly at Hackensack Meridian Health. I would expect that that will continue.
Okay, now another part of that is diversity, equity, and inclusion. Because as I've heard more over and over again, for folks to trust, to really feel as though they are a part of what you're trying to do in their community, they need to know that they're sort of that you're part of their community. And I know DEI has been an issue for you. I know the HMH has been recognized for its efforts in the past. um there's been a lot of talk about it nationally. I'm curious as to whether it's still an important component of what you do. Are you still running a robust program? Where are you with DEI at this point?
We're a very important program for us still. It's still a very high priority. I've told people, even though there seems to be some political winds that are moving in a different direction, and some companies, including healthcare, have pulled back on some of their DE&I efforts. I have told our team, and I've said this publicly, I'll say it again right now, is we're doubling down our efforts, because it's a very important piece of what we do. I truly believe that a resident of New Jersey, which is the one of the most diverse states in the country, that our workforce should definitely represent the population, but we take care of a diverse patient population, and we need to put policies in effect that help that diverse community. That's why the DE&I is connected to health equity. But we made some great strides, whether it's on the workforce side in terms of leadership, and making sure that DE&I is practiced, and that that folks, particularly from minority communities, have an opportunity for leadership positions. We also, from a board level, we just added a new class of board members. That's a significantly more diverse class. I mean, that's something that we hadn't done, at least in my career. Usually, you add one board member at a time, but through some vacancies that we had, and through some board members that now have gotten to the point in their careers where they've gone to an emeritus status as opposed to a board member, it created some openings. So we've actually added some additional board members who are very very accomplished, but also I think in the spirit of D&I, reflect the best of New Jersey.
Okay. All right. We just have a few minutes left, but so I want to talk a little bit more about what's going on at HMH and the business itself. First of all, getting back to to what's happening in Washington, there's going to be a new antitrust regime. I'm curious if you see mergers and acquisitions coming back in the future, or are you still going to pursue the kinds of things you've been doing up until now?
Well, I think we've done a little of each. So our growth has been organic, but it's also been through M&A. We've added, obviously the big merger between Hackensack and Meridian happened in 2016, but we also have added several hospitals through M&A activities. We've also partnered with several other hospitals and health systems out there, maybe not a full asset merger, but through joint ventures. So all of that, of course, is looked through the lens of antitrust. And I definitely, think with the new appointments at the Federal Trade Commission that there'll be more of a view about M&A that might be more positive, and maybe where they would see more of the benefits of that. I personally think the FTC probably went a little too far the other way, and as a result of that, unfortunately, we didn't, not necessarily in New Jersey, but we saw in other states hospitals that had to close because they weren't allowed to merge or to joint venture with other hospitals in their area, and they couldn't survive, so they went bankrupt. And that wasn't good for that community and those patients. But the FTC didn't look at that; they looked at it very narrowly, just through that antitrust lens. So I think the new leadership at the FTC is going to be a little bit more balanced with that. So I do think that you'll see some M&A activity probably increase. And listen, there's still a need for scrutiny. There's still a need to make sure that antitrust laws are protected, and we're certainly big advocates for that as well. The other area, I think that from a regulatory perspective, that might be a little bit different is the National Labor Relations Board in terms of some of the union issues that have been out there. I don't know exactly what the new policies will be, but I know under the former administration, the NLRB, in terms of some of the disputes that happened, we're more focused on one side as opposed to the other. Maybe there'll be a more balanced approach now. I don't know. So we'll see. Again, we're gonna have to wait and see what actually happens. Folks talk about different things on campaigns, right? But when they get into office, we'll see what happens and what doesn't happen.
Okay. So it sounds like M&A is something you're still interested in.
Yes, absolutely. We never stop being interested in it. It's it's just I think the environment's going to be a little bit more encouraging for it. And listen, it should only, and I want to make this point, is really important. M&A should only be used where it's going to benefit the communities that you serve. At the end of the day, it's all about our mission. In our case, it's to transform healthcare. So if an activity, if a transaction can help transform healthcare and benefit that community, I'm all for it. But if it's just for the sake of getting bigger and getting to be a bigger size, that doesn't make sense to me. It has to be a purpose behind it, and so we'll continue to look for those opportunities where there's specifically a purpose to improve healthcare in our communities.
Okay. And I want to ask you something about the health hospital rankings from like U.S. News and World Report, and things like that. We cover those all the time, and people love them. I mean, they always do well, those stories. Yeah. For what it's worth, but they're not universally loved. There's a lot of criticism of them, and HMH always does well in them. I'm curious as to what your view of those rankings are. Do you take them seriously? Do you worry about them when they're coming out, or do you care at all about where HMH falls in on the U.S. News ranking or leapfrog or anything else?
Well, we do care, and there's a couple of reasons why. Number one, as you said, consumers pay attention to them, so we need to be focused on that. We're a consumer-oriented industry, so if consumers are paying attention to these rankings, then we need to be sensitive to them. But what's even more important to me is that it's what the rankings represent, the work and the outcomes that go into those rankings. So as an example for Leapfrog, there are very specific metrics that are used that are highly correlated with patient safety. That's very important to us. So
right, and I probably shouldn't have lumped Leapfrog in with U.S. News, although U.S. News claims to use a lot of objective measures too. But I'm sorry, I interrupt.
They do. No, and I'll get to U.S. News too. But just as an example, Leapfrog, is very highly correlated with patient safety, and obviously we want to have the safest hospital environments, the safest healthcare environments. So we do pay attention to patient safety. And as a result of that, if we get a high score in Leapfrog, letter A, that's great. And, we congratulate our team about it. And we're proud of that. I mean, they put a lot of hard work in every day to achieve those outcomes. With U.S. News and World Report as well, I mean, there's specifics on mortality, on complication rates, hospital-acquired infections, nurse patient ratios. Those are all very important stats for us. So we don't practice a certain way because of the rankings. We practice that way because we want to be the best that we can. And then if the rankings come out in our favor as a result of the outcomes that we achieve, again, we celebrate. And we don't make any. We're not embarrassed by that. We do celebrate. I mean, when Hackensack University Medical Center became the #1 hospital again in New Jersey, we had a big celebration up there for Hackensack. When our children's hospitals became the #1 by U.S. News and World Report in the state of New Jersey, we celebrated. When our John Thurber Cancer Center became one of the top 50 cancer centers in the country, darn right we celebrated, because it's what went behind those rankings, that the hard work that went into it, that we want to recognize folks for that hard work, and it's the right thing to do for our patients and for our community.
Okay. Well, in that case, we'll continue to cover them and we'll continue to enjoy the page views that we get from them. So I know we're out of time, but I did want to give you a chance to wrap up and let us know, tell us a little bit about, if you can, just what we should expect in the next year at HMH. What
Yeah.
to look for?
So a couple of things I just want to say off the top. We're making major investments in our healthcare facilities at HMH. So starting with our hospitals, we just came off a huge expansion project up at Hackensack University Medical Center, an $800 million expansion, and the centerpiece of that was opening up the Helena Thurber Pavilion, which has been transformational for Hackensack. What we have planned for the starting this year and into the several years to follow is a major master facility plan for two of our other campuses, Jersey Shore University Medical Center in Neptune down at the Jersey Shore. That's our fastest growing hospital, because if you think about it, after COVID, a lot of the population migrated down to Monmouth County and Oceans County, and even folks that had homes in the north and the south, they're now living in the southern counties. So we're seeing tremendous growth. So we're going to be investing $1.3 billion into Jersey Shore for new critical care tower, new private rooms, new operating rooms. And then JFK University Medical Center, located in Edison, also we're investing a lot in some of those same areas: critical care, operating rooms, new emergency department, new ambulatory cancer center that's actually going to be opening this year. And in total, over the next several years, we're going to be investing $600 million in Jersey Shore. The other thing I'd point out just quickly, because, as more and more healthcare continues to move outside those hospital walls, our ambulatory care network continues to expand. We're investing, have invested, and planning to invest over the next couple of years about $500 million in ambulatory care. We're opening up about 25 new ambulatory care centers. That could be anything from a primary care center to an urgent care center to an imaging center to a comprehensive health and wellness center. As we just opened last year in Paramus, we're going to be opening a big one in Clifton, New Jersey this year. We opened one in Eatontown, New Jersey 2 years ago. That's really the future of healthcare, is going to be, ambulatory, where people will have better access to care. It's closer to home. It makes healthcare more affordable. So in the next year, Jeff, you're going to see major investments in our hospitals, but also major investments with our ambulatory care network.
Okay. Well, we'll leave it there. I hope you come back and tell us a little bit more about those things as they happen.
Be glad to.
Okay. Bob Garrett, CEO of Hackensack Meridian Health. Thanks for joining me. I really appreciate you taking the time today.
Thank you for having me.
And thanks for watching. Until next time, stay safe, everyone.